I want to start by telling you about a case that got me thinking about what we're really trying to pull off in many lines of work. But this is a medical case, and I read about it when it came out in a journal about a decade ago, outlining how we take care of people who've drowned and what we should do to try to revive them. It described the case of a 3-year-old girl who had fallen into an icy fish pond with her family while out on a picnic in Austria in the Alps. And the girl, it's one of those nightmare moments, was simply lost beneath the water. The parents saw her, dived in, and couldn't get her. It was at least 30 minutes until they were able to find her at the pond bottom, fish her out, get her to the surface, and then to the shore. She wasn't breathing. They called the emergency services line. The operator gave instructions on how to do CPR. About 8 minutes later was when the first emergency services team arrived on the scene, and they got the first vital signs. Her temperature was 66 degrees, more than 30 degrees below normal. Her pulse was absent. She wasn't breathing. And most ominously of all, her pupils were dilated and didn't react to light, meaning that the brain was gone. But you don't give up on a little girl. They took over taking care of the chest compressions. They got her in a helicopter and transported her to the nearest hospital. There, she was taken directly to the operating room and bypassed the emergency room. And the article outlined what the team then went through as they walked through what would you really do to be able to have a shot at saving a child in this kind of situation. Well, what it involved was getting the child onto cardiopulmonary bypass, which is not a small matter. You have to cut down over the femoral artery and vein, plug in inflow and outflow lines to the cardiopulmonary bypass machine, prime the pump, and get it all going. So it was an hour and a half before you finally had circulation restored for her. An hour and a half without oxygen and any sign of breathing or circulation. But they kept on going. They slowly warmed her body, and after 2 hours, her temperature reached 76 degrees. At 76 degrees, her heart started beating in a normal rhythm. They then attempted to warm her body further. They brought it to 98.6 degrees after 6 hours, normal. They then tried to see if they could get her lungs to work and started, they had a tube down her throat. They got a mechanical ventilator to push air, oxygen into the lungs, and they found the lungs were too full of pond water and pond debris to be able to allow the oxygen to go through. The cardiopulmonary bypass machine is made for temporary use during a cardiac operation, not to sustain people over a long period of time. So they got another machine, an extracorporeal membrane oxygenator, ECMO, which they wheeled in, an artificial lung, basically. And to plug this in, they needed to do an open sternotomy, open the chest, plug the inflow and outflow lines into the right atrium of the heart and into the aorta, prime this pump, get it going, unplug the other machine, repair the holes in the vessels, close the wound, pull a sterile drape over the patient's chest, and then wheel her, her bed, and the machine all to the intensive care unit. For the next 24 hours, they then went to work suctioning out the lungs, cleaning out the debris every few hours. And amazingly, they were able to get the lungs now working. When they tried after 24 hours to start the mechanical ventilator, the oxygen would pass across the lung membrane into the bloodstream, and carbon dioxide would come back. They then supported her in the intensive care unit through the next phases of care. They needed to take her down to the operating room and unhook this ECMO machine, close the holes in the heart and the aorta, pull the chest back together, then work on drugs and therapy to help support her liver recovering, which was in shock. Her kidneys were in failure. But after 48 hours, they had all of the organs back, except one, her brain. At that point, they'd stabilized her enough, though, they felt they could safely transport her to the CAT scanner, and they scanned her brain and found that the brain had swelled against the limits of her skull. But there were no dead zones, no obvious areas where there'd been a stroke from the loss of oxygen, at least as far as they could see on this scan. So they kept going. They got a neurosurgical team, and they drilled a hole in the skull to relieve the pressure from this swollen brain and to place a pressure probe to allow them to monitor the pressures, and with that dial the medications and fluids up and down to reach the right endpoints. And then they watched. For the next week, she was comatose, and then slowly, she came back. First, her pupils began to react to light, and then she began to breathe voluntarily. And then one day, she just woke up. She was there. A week later, she went home. She was not done. Her right leg and right arm were paralyzed. Her speech was severely slurred. They had to do occupational and physical therapy along with neurological therapy intensively week after week. But 2 years later, she came back to the hospital and underwent neuropsychological testing, and it showed that she was actually back to normal. Her right arm and right leg had equal strength to her left side. Her speech was no longer slurred, and her psychological and mental skills were at her proper age. She was, in other words, like any other little girl that you and I know. Now, this case struck me, and it struck me because of two reasons. Number one, that we'd learned enough to bring someone back from an hour and a half in a condition like she was in, with no oxygen or circulation. But the second is how much was required in order to pull this thing off. This was not Gray's Anatomy, with a few chest compressions and the child would suddenly come coughing and sputtering back to life. This was dozens, perhaps even hundreds of people needing to carry through an incredibly ambitious project from beginning to end, one right after the other. And if one person even just failed to wash their hands and an infection got in under the drape, the game was over. Every one of those people had to be able to make it go right. And they did. What happened with that drowning girl? What I didn't understand reading that report is how they strung all of those things together, that incredible series of care that had to happen. And so I called up the lead author of the report, Marcus Thalmann, who's a cardiac surgeon at the hospital in Klagenfurt, Austria, where she was saved. And this is what he told me when I asked him how things were done. He told me he'd been working in Klagenfurt for 6 years when the girl came in. She had not been the first person whom he and his colleagues had tried to revive from cardiac arrest after hypothermia and suffocation. His hospital received between 3 and 5 such patients a year, he estimated, mostly avalanche victims, some of them drowning victims, and a few of them people attempting suicide by taking a drug overdose and then wandering out into the snowy alpine forests to fall unconscious. For a long time, he said, no matter how hard the hospital's medical staff tried, they had no survivors. Most of the victims had been without a pulse and oxygen for too long when they were found, but some, he was convinced, still had a flicker of viability in them, yet he and his colleagues had always failed to sustain it. He took a close look at the case records. Preparation, he determined, was the chief difficulty. Success required having an array of people and equipment at the ready: trauma surgeons, a cardiac anesthesiologist, a cardiothoracic surgeon, bioengineering support staff, a cardiac perfusionist, operating and critical care nurses, intensivists. Almost routinely, someone or something was missing. He tried the usual surgical approach to remedy this: yelling at everyone. But still, they had no saves. So he and a couple of colleagues decided to try something new. They made a checklist. They gave the checklist to the people with the least power in the whole process, the rescue squads and the telephone operator, and walked them through the details. In cases like this, the checklist said, rescue teams were to tell the hospital to prepare for possible cardiac bypass and rewarming. They were to call, when possible, even before they arrived on the scene, as the preparation time could be significant. The telephone operator would then have the power to work down through all the list of people to notify and instruct them to have everything set up and standing by and to have them go through their own checks. With this checklist process in place, the team had its first success: the rescue of the 3-year-old girl. Not long afterward, Thalman left to take a job at a hospital in Vienna. The team, however, has since had at least 2 other such rescues, he said. In one case, a man had been found frozen and pulseless after a suicide attempt. In another, a mother and her 16-year-old daughter were in an accident that sent them and their car through a guardrail, over a cliff, and into a mountain river. The mother died on impact. The daughter was trapped as the car rapidly filled with icy water. She had been in cardiac and respiratory arrest for a prolonged period of time when the rescue team arrived. From that point onward, though, everything moved like clockwork. By the time the rescue team got to her and began CPR, the hospital had been notified. The transport team delivered her in minutes. The surgical team took her straight to the operating room and crashed her onto heart-lung bypass. One step followed right after another, and because of the speed with which they did, she had a chance. As the girl's body slowly rewarmed, her heart came back. In the ICU, a mechanical ventilator, fluids, and intravenous drugs kept her going while the rest of her body recovered. The next day, the doctors were able to remove her lines and tubes. And the day after that, she was sitting up in bed, ready to go home. Thank you.